Okay, I'm actually starting a couple of minutes early to make a couple of announcements. The first announcement regards the Friday poster session. Of course, we grew so much that we had to have two poster sessions. So we had a Friday poster session over lunch, a box lunch, as well as today. So I don't have the results for today, but I'd like to announce the winner, the #1 voted poster, the best poster out of 52 posters, according to the conference vote, was presented by Denise Alfaro of the Public Health Program at Patterson University, William Patterson University, Rosario Garcia, also a public health student at William Patterson University, and their assistant professor mentor, Corey Hannah Bash, who is assistant professor in the Department of Public Health at William Patterson University. And the name of their poster was Using Spike Lee's When the Levees Broke to Initiate Discussion About Disparities in a Public Health Education Methods course. So congratulations to them. And then, turns out that I've been doing quite a bit of recruiting for our doctoral program in particular. So you should know that if you have an MPH in public health from Columbia University, I really don't see how we could reject you as a doctoral student in our EDD program in health education. So please apply. We have rolling admissions. So if you want to go home tonight and do your personal statement and upload a sample of your writing, then please do so, because we're going to give out our financial aid on Wednesday. So if you've also applied for financial aid, not having to demonstrate need, just having applied, then we could even consider you at our Wednesday meeting for financial aid. And this is a recruitment booklet. There are a few left at the registration table. It's also online at our website. So go to the Teachers College website, and then go to Program in Health Education and read about how we accept up to 45 credits that you can transfer from your graduate program if you have a grade of B or better. And now for the moment we've all been waiting for. I'd like to draw your attention to the detailed bio and photograph of our two featured speakers. First, Dr. Robert Fullilove, who doesn't require a PowerPoint. And then we're gonna have Dr. Chandra Ford, and as I understand, we probably should kind of walk up to her and congratulate her, because she might have good news coming in her life soon that's public. Right now we know it's private, but it's well-deserved good news. So you want to meet her because she's up and coming. So let's go to the person who's going to engage us without a PowerPoint and show us who are dependent on them how it's really done. Let's go to Dr. Robert Fullilove of Mailman School of Public Health. The one, the only. The other half of my dog and pony show at Teachers College.
So I'm not sure whether I'm the dog or the pony, but I do want to make it clear that as a graduate of this institution, the extending of an invitation for those of you with an MPH who'd like to get a doctorate here is sincere. You need to do that. Dr. Wallace and I have been doing this for what, 15 years now? I am told I have probably served on more dissertation committees than any other member of the faculty of this institution. And I've lost count, but I think I'm above 500 now. I do more in some years than people do in a lifetime, and I want to really believe that all praise is due to Dr. Wallace, because she has really created a pipeline that has made it possible for a whole bunch of us to find our way into the annals of public health, into the corridors of public health, to the communities where public health is done. Armed with an appropriate credential, it does in fact make a difference. That's the good news. Part of what I really want to reflect on is some comments that Mindy Fullilove made earlier. As you can well imagine, I owe a great deal to the good Dr. Fullilove. I think I'm the person who often describes himself as the footnote to the work that Mindy has been doing as a pioneer in urbanism over the course of the last 20 some odd years. My major contribution to her work has been the fact that I'm the French speaker. And if you get a chance to read Urban Alchemy, you'll see that a major portion of what she does is talk about our travels in France and our connection to Michel Cantal-Dupart, who's an urbanist in Paris, who's taught us a great deal about cities. A great deal about cities from the standpoint of being in a place where the cities work. And don't get me wrong, France is not a place that is free of racism. There's more racism in France than there is in some parts of the South in that nation. But what they have managed to do is build cities that have stood for 1,000 years. And one gets the sense that we could be doing better with the cities that we have, particularly since they are, at the moment, I believe, places where it's very hard to do the work of public health because we're dealing with a moving target. How many times over the course of the last 2 days have you heard folk invoke the notion of gentrification? Well, a lot of what's happening with gentrification is that the historic communities that many of us have been accustomed to working with are slowly but surely disappearing. I'm sort of recalling all the folk who said, I live in Harlem. It's sort of weird to see how over the course of the last 20 years it's changed. A lot of us are trying to figure out how you do community-based public health that fundamentally depends on the creation of social capital amongst members of a community, when the community itself is a collection of strangers, where large numbers of folk who are there have only been there for a short time, and many of the folk who have been there for a longer time are getting ready to move. Social capital is really basically that non-monetary piece of resource that exists in social networks. It takes time to develop social capital because one of the fundamental attributes of that kind of resource is trust. You don't begin to trust somebody you just met yesterday. You don't want to invest time, energy, money, and maybe your life's work working with strangers. So if you're in a community that you're trying to improve, where you're tackling health disparities, and you want a community-based response, part of what you're depending on is the fact that when community members come to you, they can work together to create what we call collective efficacy. Collective efficacy means that the group has the wherewithal, the knowledge, the understanding, the intelligence to be able to look at a problem and work together to solve it. Harlem is now a place where a lot of people look alike. A lot of us are black and brown, but we don't know each other. So the whole notion that you're going to, on a Saturday or a Sunday, go to a meeting to talk about the problems of Harlem, that doesn't happen. It might have happened many years ago. The Harlem that I knew 50 years ago, and yeah, I'm that old. The Harlem that I knew 50 years ago was a very different place. It was, as I think Mindy probably described in her talk, a neighborhood of neighbors. People knew each other. If she did that slide where she shows eyes on the block, some of you are old enough to remember a time when we didn't want to keep the kids inside. We wanted them to go outside. We wanted them to run, rip, and ramble because we knew that there were people watching out for their best interest. Now in some of our neighborhoods, if we're not worried about somebody driving through and snatching a youngster off the street, we're worried about whether or not they're going to get embroiled in the community violence that seems to be so ever present. And a lot of us are trying to figure out how do you do the work in places like this when the most important thing that you need is the thing you don't have, the trust and the connection that exists between neighbors. Now, some of you have heard me speak before. A good number of you have had classes with me, so forgive me if I repeat some oft-mentioned themes. I've always been of the mind, since I became first aware of the impact that mass incarceration was having on our communities, that one of the problems that we were examining was a problem that was created when so many men left the community. I used to talk about HIV/AIDS as an epidemic in African Americana, which was being driven by the prison industrial complex, with folks circulating in and out of prison, a circulation that probably exposed them to the virus either on the inside or in the community. But over time, I've been convinced that the real damage that was done by mass incarceration wasn't just that it created vectors for the transmission of HIV. It's that it took one of the most important and vital resources out of the community and rendered them, for all intents and purposes, incapable of really functioning as community members. Mass incarceration in some communities, as you know, takes as many as 35 to 55% of all the young men between the ages of 19 and 35. And one has to wonder, What kind of functioning can exist in a community where so many adults are missing? What happens to the kids? We've been talking a lot about education. We've been worrying about what happens to black men and young black boys as they're going through school. Well, I want to suggest that in another day and time, much of what was present to give young men a sense of backbone, I said blackbone, didn't I? Backbone, that's a good Freudian slip. I'm sorry Mindy wasn't here to hear that. Was the sense that there were men in the community who were automatically your mentors. And the men in the community weren't necessarily the folk who were dealing drugs or who were running numbers or anything like that. We had a gamut, a diverse gamut of males who were part of the process of growing up. Now, some of you know about the concept of million-dollar blocks. There's a group at Columbia that has been actively researching what it is to be in a community where so many men on a given block are locked up that the cost of their incarceration to the state is in excess of $1 million. There are something like 54 of them here in New York City alone. What does that say about what's going on in these communities? It says a lot. It says a lot. But I don't want to dwell on that so much as I want to dwell on the fact that it seems very clear that when we talk about the school to prison pipeline, part of what we have to figure out is whether or not, as Professor Edlin said this morning, we shouldn't, as public health people, be very much about education as the last institution standing in the community where we have an opportunity to make an impact. If so much of your life is dependent on the kind of education that you get, if so much of the work that you do is based on what it is you get in a classroom, if so much of your health depends on the quality of education you've gotten, then maybe the primary causes that we need to be concerned about are those that take place in the schools. I have to tell you, I have had a real moment thinking about this because, as some of you know, I've been involved with the Bard College Prison Initiative now for 6 semesters. It's 3 years. I taught classes at, and for those of you who know these names, I know you'll smile, Woodbourne, Greenhaven, Eastern. It's really interesting. Bard College, as many of you know, has been in operation using its prison initiative for the last 15 years. It's now graduated something like 750 formerly incarcerated persons who now have BA degrees and who are doing very well. Governor Cuomo specifically mentioned the prison initiative because when you look at the recidivism rates for young men who've gotten a college degree in prison, it's something like 3 to 4% as compared with 70% for folk who are in the general population. 70% versus 4%. Cuomo pointed out that it costs $5,000 to educate a man or a woman in prison. It costs $60,000 a year to keep somebody incarcerated. So what he tried to do was say, we've got to, as a state, begin to invest in college education on the inside. And for those of you who are educators, let me just say that this is the new frontier. Why is it the new frontier? Well, number one, folk who are taking classes with me at Woodbourne, thank you, are folk who are real college students. They had to pass an entrance exam. They had to submit a writing sample. They had to give an interview, had to be a part of an interview where they made it really clear that they understood what it is they're doing. I've got 22 students now in a class that is looking at chronic diseases and health. It's a mirror image of the one that I teach at the Mailman School of Public Health on Wednesday nights. I'm fond of making comparisons. My students at Woodbourne basically get a bunch of reading from me on Monday. When I come back the next Monday, wait for it, they've all read the assignment. Y'all Columbia students who've gotten really, really good at skimming, at looking at abstracts, at figuring out by looking at the opening paragraph and the closing paragraph and what it must be saying, pale in comparison to what my boys are doing. Now, it's true, they're a captive audience. They really do understand that there isn't much else to do other than work. But it's not just that they're putting in the time and energy. It's having them describe how they are now understanding something in the joint that they didn't understand when they were in school in the community. Now they're getting serious. Now they're really sort of understanding, duh, there was a lot I could have done to avoid being in this place. Now I'm talking about folk who, I'd say the average amount of time that my students have done somewhere between 15 and 19 years. I've got guys who came in at 17, have been in for 25, have another 10 years to go on their bid, and who've never known the modern world as we know it. The idea that this has now become a moment for them to reflect on who they are, what they are, and what they can do in their communities when they return is something that has the preacher in me thinking it's time for an altar call. Because all of a sudden I'm beginning to understand that even in these hard economic times, I believe there are places that these young men and women will occupy at the point that they get out. And I think that's absolutely crucial. Remember the program Scared Straight, where we used to take kids for a day into the joint and we try to scare them? What happened in all too many of these places that the young men walked in rolling en roue la mécanique, as you say in French. And they would say, I could do this, I can do that, I can handle this. Instead of scaring them, it gave them a notion like, okay, I see where I'm gonna be, and they're already taking the measure. They're already getting the lay of the land. I think what I've seen that is unbelievably effective is what happens when somebody like this comes back to the classroom, maybe in the high school that they attended, perhaps in the high school where they dropped out. And they start to talk about, okay, you want to go back there? I just did 20 years. I have no intention of returning. And you, knuckleheads, you should be thinking about what am I going to do to make sure that I'm not there. I'm really impressed with the degree to which many states like New York are suddenly rethinking the economics of mass incarceration. It's costing states so much money to lock so many of us up that they're now rethinking the economy and the economics of having such a large portion of their citizenry, not just locked up, but coming home as second-class citizens without the right to vote, get educational loans, work in many settings because of their records, or even qualify for housing. I mean, it's not just that it's costing the state money to keep them locked up. When they come back unable to integrate into the intricacies of community life, it's costing the state money again. And if they go back to prison after 3 years, this cycle is infernal. So you're going to start to see over the course of the next couple of years small but modest programs that say, now that we've gotten them out, how do we keep them out? And the question of what we're going to do and how we're going to do it is going to become paramount. And I think people in health education and public health have to be engaged in that conversation. They have to be a part of that discourse. I've been training people to understand something about the principles of public health because I'd like them to take care of some of the things that are coming available as a result of the Affordable Care Act. The Public Health Prevention Fund is a pot of money that, at least in principle, should be making it possible for us to work in medically underserved areas, to identify folk who are hidden from us so that we can bring them out, provide them with insurance, and slowly but surely transform our system of sickness management to one that's really public health, where people are having regular checkups, are identifying chronic diseases at the point that they're starting, so they don't become chronic in terms of our having to pay for their care later on. I mean, the logic of the system is, I think, impeccable. And the issue is, do we have the folk present in the communities who can say to folk, hey, I know you don't trust hospitals. I know you're a little worried about doctors. Tell you what, I'm here with you. Let's go, sign you up. Let's get you that checkup. Let's see what we can do to make sure that if you have a condition that needs to be monitored, you got somebody in the community, me, who's going to make sure that this works out. It's worked in other settings. This isn't new with me. Those of you who know about Jim Thomas's work at the University of North Carolina, Chapel Hill, know that we've already established how useful it is to have, and forgive me for using this term, indigenous healthcare workers doing work with us in communities. And in communities where folk are kind of, as I've suggested in my opening remarks, falling apart, where they're not connected to each other the way they used to be, where the whole issue is how do we create trust so that, amongst other things, they're becoming engaged in public health interventions becomes possible. Seems to me that this is the point where young men and young women who are currently getting an education on the inside have real contributions to make to the work that we're doing. I think it's also important to point out that, forgive me for saying this as well, I have been a predictor of hard times. I think the first talk I gave in this conference is one where I said, you know, hard times are coming. I think I said I really worry about our ability as people in public health to continue to function in a system where if we don't have the money, if we don't have the cash, we can't do the work. I said almost all of us have become soft money junkies. Those of you in public health know you don't have a career, you have a series of projects. And those projects are all funded by whatever is the flavor of the month with funders. And some of you are already looking at the fact that with the cutback in government services and with a Congress that seems bent on reducing the size of government, even those of us with doctoral degrees are suddenly looking at the possibility that we are going to be out of work. Or at the very least, we're going to be struggling to find positions that are funded by an ever-shrinking pie. We're all trying to be competitive so that we can get our share of something that is slowly but surely dwindling before our eyes, are we not? So it's weird to think that at this point in the 21st century, where we've probably done more to create a more diverse, educated workforce amongst blacks and Latinos, we're suddenly discovering that the last hired, first fired expression from the 60s is back. I've had a number of cab rides coming from LaGuardia to my apartment in Harlem where I've been driven by somebody with a master's degree from a good school. And they all say they're sort of in between, one thing and another, but at some levels, all of us have this sense that we're in between one thing or another. And we're all sort of waiting to see whether or not the continuation grant that we put in is in fact going to allow us to continue to keep going. Those of you who are aware of the polemic at the School of Public Health know that even there, senior faculty, who all basically have dollars dependent on soft money, worry about their ability to sort of stay. So it's a way of saying that this is affecting all of us. Not only is it affecting all of us, it seems clear that the way that we have thought about correcting this situation is not so much based on what we can do in communities. A lot of you are thinking about going back to school. When somebody with a PhD tells me they're thinking about going into nursing because there are jobs there, I'm pretty clear that this system is broke. And a lot of you are looking at each other. You can say amen if you wish. Because you're right. It's not just you. I'll say that again. It's not just you. It is that bad. I come from an era when what we were about was community organizing. And be clear, I'm not trying to say that those were the good old days. There was nothing good about them. I'm just old, so I get to talk about life back then. Some of you know that in January I turned 70. Yeah, I look good, don't I? And Dr. Wallace is smiling because every speech I find a way of milking applause out of telling people how old I am, And trust me, the next time you hear me talk, I'm going to do some version of the same thing. But the take-home lesson is very simple. I have been around. I have seen it all. I knew what it was to do community organizing work in Mississippi 50 years ago with Mississippi Freedom Summer. And as I'm fond of pointing out ad nauseum, we did that without grants from NIH. We did that without grants from the CDC. Somehow or other, poor communities, and you have not seen poverty until you've seen poverty in Mississippi. Somehow or other, poor communities manage to collect the resources necessary to make the movement possible. Now, my sense is that it's going to be hard to return to those old days right now in communities where people are moving, where gentrification is the law of the land, and where it's hard for folk to imagine that they're going to be in a place long enough to make organizing that community possible. So that's one of the reasons why I'm suggesting that the place where we need to begin may not be the kind of door-to-door, house-to-house community organizing we did 50 years ago. It probably has to begin fundamentally in the schools, because there we have the opportunity, we have the capacity to work with a group, as so many speakers in this conference have pointed out. We have a capacity to work with a group that were they able to see themselves the way we see them, full of promise, not potential problems. Were they able to see what we see? What could we accomplish? It's important to recall that the Student Nonviolent Coordinating Committee was one of the most important civil rights organizations of the 60s, and it was students. It was students, but it was students with adult help. It was students with Bayard Rustin. It was students with a lot of the senior people in the black community whose names have all been forgotten by history, but who are recalled by some of us because they were there at a moment when our youthful exuberance could have gotten out of hand, and they said, chill out for a second. Think this through. There are things to be done. Let's have a strategy instead of a knee-jerk response. My belief, if I can make another prediction, is that we are about to have another spasmodic incident in the United States where all of a sudden the world that we know is going to contract so suddenly that it's going to be as if God pushed the reset button. So that a lot of the work that we do is going to suddenly be under a very different set of circumstances than the ones we're accustomed to. My thought is, rather than hope that the future will look something like the glorious past, my thought is that what we have to do is literally be conscious of the fact that bad times are in fact coming, and that the way you survive bad times is to gather the wagons together, put them in a circle, and let's begin the conversation where, amongst other things, we talk about what are we going to do together. What we are good at doing in education and institutions like this is creating individual intellectual entrepreneurs. We haven't actually done that much to create think tanks where all of a sudden we're all pooling our intellectual resources and thinking, how do we as a collective solve this problem? Many of us don't have the time or the energy. Many of us are giving, 15 hours a day to our job, so we don't have any time for anything like this. This becomes a hobby or a pastime, where even for many of you, coming to a conference on a Saturday represented something of a sacrifice because you could be doing other things. But if you're here, I suspect it's because you know there's a real need out there to have these kinds of conversations, to have these kinds of discussions. And let's be clear, because so many of us are from the same intellectual, institutional family, we have a lot in common. And wherever we may be, there is something in the way of a stable element that stems from the fact that we all got our training here. I started here in 1972. That's a while ago. Anybody here been here longer than me? So, if I can come back, I have this sense that we need to have a kind of a let's come home gathering, where instead of having talks, instead of having lectures, instead of having these kinds of exchanges, we sit around and say, let's do some problem solving. Let's get into some collective efficacy, whereas an intellectual community that is spiritually connected to the issues that are raised by health disparities, we start thinking about who else can we engage and where can we go as a group to figure out how to do some problem solving that isn't so dependent on funding and soft money. Knowing full well that there's an incredible amount of energy in the communities that we represent. There's an incredible amount of creativity in the communities that we represent. And who better than us to figure out how to tap it? Don't you get a sense that that's really what we're going to have to be about? I mean, this notion that somehow or other you can burrow down and make yourself even better than you already are is a good one. By all means, self-improvement, let's do this. Lifelong learning. As educators, we got to be about that. But at the point when we have done what we can to develop ourselves, if we're concerned about the communities where we work, and you, like me, have a sense that, ooh, it's going to get worse before it gets better, then maybe the whole notion that we should be organizing, connecting, not just for a day in a meeting like this, but on a more permanent basis, perhaps using the good Dr. Wallace's Health Disparities Research Group as a sort of a foundation upon which to do this work. Not just to write articles, not just to get grants, but to really think about the future and ways in which planning for the future will help us not only anticipate it, but God help us, maybe even control it. Thank you. She said, leave time for questions. That was supposed to be provocative, so.
Yes. I changed my glasses. That was a very bad idea.
We're waiting with bated breath.
So, we started at 2:15, and you have 45 minutes.
Right, and you said leave time for questions.
Which means that you have left 18 and a half minutes for questions.
Okay, good. And also,
So-
am I
so-
not supposed to be dashing over to some other place so that?
Yes,
I also
that'll
left
work
time to
out.
run.
That'll work out. So that's interesting that you just have given me
the possibility of an assignment to use the research group on disparities in
I mean,
health
seriously, haven't you wanted
as
to do
a
that?
think tank for bringing people together and problem solving. It's interesting because just over lunch, the sister right over here from North Carolina, Bethel, Dr. Bethel, inquired. She's like, well, how can I become a member of the research group on disparities in health? And I said, well, you know, we meet on Wednesdays, and so the details are from 3:20 to 5. And I said, I'm not so sure I'm ready to have that group be an online experience where people are participating through Skype. I said, plus, sometimes we have some rather frank moments that occur that I'm not sure for public consumption. But now you have just put it back on the table as a possibility that perhaps once a month we should have a potentially international or regional or whoever wants to come online to have some kind of conversation. And on top of that, we have Dr. Rhoda Zian Alali, who just told me that she is going to, I think it's, I forget who, she wants to make available the funds to make the Fishbowl a green, eco-friendly conference room, that she wants to upgrade it. So that means that I've got 3 things coming at me all at once saying this is perhaps possible, to actually have a technologically advanced room that's also low on electromagnetic energy, that's not toxic, and to really facilitate this kind of once-a-month discussion. So what are you doing at 3:20 to 5 on Wednesdays, Professor Fullilove, since a dog can't do anything without a pony?
I'm always preparing for my 5:30 class. But I like this in principle. I was hoping somebody would say, okay, well, what would you do?
Yes, that's my question.
In 1970, I was a master's student at Syracuse University, and I had a professor who was really interested in futures studies. Those things still exist, but future studies basically use Delphi techniques to have folk, and this is how I would begin, make predictions about what do you see coming in the next 5 years, 10 years, 15 years. I think part of the way to make a group like this be something other than a place where people chat is to have us focus on a set of targets that we think are coming. So I imagine there's going to be a lot of diversity in what people are going to come up with as predictions. I would do them in a variety of sectors, community, public health. We could even choose them as a sort of a collective. But I would like to see whether or not, because this doesn't depend on people being present in real time, whether or not some set of iterations of an effort to sort of make predictions about where things are going. And then say, okay, if we've identified these as problems and as issues and as points of foci, what do we do about them? And how do we do that? There was a time in the 70s when people got funded to do this kind of thing because the predictions, especially about technology and where it was going, was of great interest to a lot of people, for example, in the then early stages of the computer industry. So I have this sense that instead of just focusing on all the difficult things that are happening now, which all of us do research to describe, taking sort of the point that what we really want to do is anticipate what's coming might be a way for us to organize our thinking about what to do next. Because I think that's what all of us are wondering. What do we do next? Now, you might be wondering, if I'm 70 years old, you know, how long am I going to be at this? Well, I can't afford to not work. So my plan is to be around for at least another 15 years. And I want to believe that, you know, what I'm proposing for many of you is to engage in something that for us would be something like the next chapter. Wherever you are in your career, the next chapter is one that isn't just looking at the present and trying to understand what's happened in the past. It's also really engaged in thinking about the future. And I know that Professor Hernandez, who's speaking at 4 o'clock, is someone who said, look, I hear you talking about soft money, because she's all about being entrepreneurs. So as intellectual entrepreneurs who have some kind of focus in health education and public health, what are the ways in which we can make money? Am I correct, Dr. Hernandez? Yeah, because I knew you were going to ask, and I'm just going to put it on you instead. What are the ways in which we can do this kind of work so that we create our own capital instead of figuring out how to compete for it? because that's what we're all about. That's what we're doing. We're competing typically with each other to get this dwindling portion of the pie. So the notion that you want to create capital as well as just simply move it around, make something other than a zero-sum game, I think that's what we have to be about.
Thank you so much for that talk and for the talk at lunch as well, because I'm one of those people that you were referring to about the PhD going back to school for another degree, and realizing that even with all of that, I am still going to be losing my job. And then also realizing that when you asked me before, well, what are you going to do? Are they responsible for giving you a job? And I said, yeah, but I don't want that anymore. It's time for me to break out and do what I'm meant to do and to make a way, because I know, and this is what I've been telling folks, that this is coming. Right now, this is the battle-ready phase, but the revolution is coming. And this time, it is going to be televised, because it's going to be in your face, it's going to be there, and we do need to prepare people who can be intellectual entrepreneurs, but intellectual soldiers as well. Because we do need to come together as a collective entity and realize that all of us have gifts that can support the work that everyone is doing, but we need to make sure that we can come together and build up leaders who can do this kind of thing. So one thing I wanted to respond to you, Dr. Wallace, is to say that rather than having me to join in on, or others to join in on the Health Disparities Research Team, why don't we create a hub in North Carolina? That way, it becomes that linkage back. We can grow a hub that can then come once a month or once every 6 months or whatever to link back, but now we're collectively spreading the word. So you grow a hub in North Carolina, and it will all grow out of this. We grow a hub in Connecticut, we grow a hub wherever. And that way, that's how we're starting to spread these networks. So then, by the 10th year, now you've got 300 hubs, people coming together as alumni, and we can talk about these issues because there are some issues that are specific to our state and to our region. So I'm excited about the possibility of doing that, and I'm excited about what's ahead, because what's happening right now is no accident. And I think it's pushing me, I know, to another level intellectually, and to say it's time to really become that intellectual entrepreneur. So thank you for that term. So I've learned 2 terms since I've been here, microaggression and intellectual entrepreneur. But I think that those are really important things to understand, and how we respond to those, I think is going to be very important over the next several years. So thank you.
Thank you. I'm going to take that as an affirmation. Professor Annie.
I just want to, first of all, say that every time I hear you speak, I learn something new and make new connections. So it's always a pleasure. But I do want to get to this question of making connections actually with the collateral consequences of mass incarceration, and the very notion that there are people that are forever impacted by their experience in being involved in the criminal justice system, and what that means for them individually, but also what it means collectively for the communities in which they're from, and that they may return to or not, given issues around gentrification. But more importantly, thinking about entrepreneurship, and not just the kind of intellectual entrepreneurs that I think may in some ways be able to deal with this whole issue of uncertainty in academia, but also creating opportunities for people in their own, so that we have more than just the kind of the educational institution, and now we're creating real enterprise, and how that can actually come from intellectuals and from people who are impacted but have had time within the criminal justice system to be away from things and reflect, and then may have the energy to come back and be entrepreneurial. I think that there's something kind of inherent about our community in terms of the entrepreneurial project, but how, like, are there concrete ideas? Are there concrete ways to build that up in our communities? And then for the purposes of health and other social determinants.
Well, I think the answer is that there are, more than anything else, folk who are motivated to do this. So what I'm describing, I think, is potential. How the potential gets expressed and realized is, I'm suggesting, what we're going to ultimately be about. I know that I got a lot of guys coming home who are really ready. And they're going to look to us and say, okay, you need soldiers? We're here. We should be training them in addition to engaging them. But I do see this, at least for me, as an important re-infusion into community life, an element that has been lost and has basically been moribund for too long a time. The notion that we re-engage with each other, I think, is an idea whose time has come. Thank you. My brother.
Hello. I really enjoyed your speaking today, and I just wanted to comment on the fact that although I do agree that a lot of communities, we've seen it from other speakers about how the tools of working as a community, as a group, helps us in general, and our communities are scattered. The issue also is in our own fields, our educators are scattered. We have health education organizations that don't refer within themselves their issues with, well, if I know that I need this many people a month, I'm not going to refer to that person. They look good, and the money's short. They're going to fire who they're going to fire. We have us hoarding clients. We have us not referring here. People who, in research, sometimes come back with people who are more in the field, like the field people are saying, oh, these researchers, they give us all this data, but what are they doing? The researchers say, we're giving them all this data, but they do what they're used to doing. And there's all this division. How are we going to help the communities if our own organization is so divided as well?
Yeah, I mean, I think it's important to say that what I proposed is not without challenge. There's a whole bunch that has to be done, and we all exist in a system that's broken. So what you're describing are ways in which it's broken. I think nothing kills creativity like competition, where folk who should be collaborators are competitors, where they're competing with each other. And that's where a lot of us are. I like you, I like your work, but your agency and my agency are going after the same grant, so I'm sorry, man, we can't talk. How crazy is that? It's America, no question about it. It is what happens in a capitalist system. So the issue of how do we get out of that is what I'm trying to address. And the idea that if we do it in some setting other than the ones where we work, we're sort of free to do things in that kind of circumstance that we might not be able to do when it's at our desk, at our jobs, working with the same suspects, if you will. So I want to be clear, once again, that this is not a panacea, not by any stretch of the imagination, but it is at least a modest proposal that I think strikes a respondent core in many people's hearts, and that's really what I want to build on. And I want to be clear that I don't see this as stuff that's just about blacks and Latinos being together. If you're engaged in this work, you know, what you need is all hands on deck. Chris was very right to say that we have gotten this far because we had allies. Well, we need allies now more than ever. And it seems to me that a moment when right-thinking people get together and decide to identify, as you have very eloquently done, the nature of the challenges that are before us, but who figure out how to get past them. I think we're capable of doing that. And that's the preacher in me, you know. I'm the eternal optimist. And maybe it's because working in Mississippi in '64 when people were shooting at me to try and get black folk to register to vote, to be alive at a time to see a black man get arrested on the one hand and then become president of the United States on the other, a guy who admitted that he used drugs as a young man but still managed to get to the top, you know, job in the land. Oh yeah, times have changed. Times have changed. This is not the old days. This is not the new days. This is a wholly unanticipated set of days. And it seems to me that when things are not anticipated, that's when we become creative. That's my hope.
One last time, I promise it's short. But how do we get the community to see us coming together as a whole? Because I really believe that the community looks to us as role models. They see us divided, and they are like, oh, well, maybe either I want to deal with them, they don't know what they're doing, or better yet, I can play this person against this person, and they use old habits. How do we get the community to see us come together on a regular basis to see, okay, our community educators, our health educators, our people who are going up there are working together? Oh, sorry.
I just want to be clear. First principle of community organizing, you don't have to get everybody. You just have to get enough. There's a big difference. When we were doing voter registration campaigns in Holly Springs, Mississippi in 1964, we had 15 people march up to the registrar's office on a Friday, and with all these folks gathered around with cops all over the place, they said, we want to register to vote. 5 years later, they had 2 city council people who were African American, and they were electing somebody to the state legislature. You don't have to get everybody, but you do have to have a start. And it seems to me that as long as we define our objective as getting everybody involved, hitting a home run, if you will, the first time at bat, we're not going to get there. But there are all kinds of folk who already like what it is I've said, who like what they've heard, and who know that, yeah, I'll sign up on that if you can just tell me where to go. I think that's what we're building on, and that's my hope for the future. Thank you.
Yes. Ms. Simonis, I would like to apologize to you because I didn't know that gentleman would ask 2 questions and you'd miss out on your opportunity. So luckily we believe in forgiveness and pardoning. Okay, so we are delighted now to be able to introduce Dr. Ford. And please come to the 5:30 to 7:30 evening dinner where you can sit with Professor Fullilove and ask your question, Ms. Simonis. And so without further ado, a rising star on our national landscape, Dr. Chandra Ford.
Hello. Thank you for this opportunity. Let's see, did Dr. Fullilove leave yet? I just wanted to say it's a tremendous privilege to be on a panel with Bob Fullilove. Years ago, when I was a doctoral student at the University of North Carolina, he delivered this brilliant and amazing speech without a single PowerPoint, in which he detailed exactly how the emerging HIV epidemic among African Americans, as well as a rapid expansion of HIV infection among crack users, especially African American crack users, could be tied to a single form of racism, and in particular, racialized policing, what we now call stop and frisk. And that work has been very informative for me because it helped to show how, as public healthers, we have a responsibility to think about things like racism in terms of their epidemiologic and etiologic potential, so social etiologies, in explaining the disparities that disproportionately affect our communities. So the title of my talk is Racism, African Americans, and Selected HIV/AIDS Disparities, a Public Health Critical Race Exploration. And I hope that you see some of the connecting points between the discussion we just had and the kinds of things that I'm working on in my own work. So what I want to do first is review the epidemiology of HIV/AIDS and HIV/AIDS disparities, assess the state of the empirical evidence linking racism to HIV/AIDS disparities, introduce the public health critical race praxis, and explore some principles and approaches from this praxis that might help us to improve how we go about doing this work around HIV/AIDS disparities. So 1.2 million people are living with HIV infection in the United States, and about 56,000 new infections occur annually. This has been rather stable over the last at least decade or so. The majority of people who are HIV positive acquired their infection through sex between men. 41% of people who are HIV positive acquired their HIV infection through heterosexual sex, 12% through injection drug use, and 4% through the synergistic relationship between MSM and injection drug use. Okay. About 75% of HIV infections occur among among men, and this is true across race and ethnicity. The majority, 70% of people who are HIV positive are in the age category 25 to 49. 1 in 4 HIV infected US residents is an older adult, and by older I mean not really that old, just 50 or older. And that category is actually expanding. Now, when we think about African Americans, who represent about 13% of the US population, HIV positive African Americans are diagnosed at later stages of HIV infection. Upon diagnosis, have worse prognoses, have higher rates of AIDS-related mortality. The period from diagnosis to AIDS or to AIDS-related mortality is shorter for African Americans than for whites. About 20 to 25% of US residents who are HIV positive are HIV infected but unaware of their HIV positive status. But for African Americans, there's an estimated 33% of African American men who have sex with men who are HIV positive but unaware of their HIV positive status. Perhaps paradoxically, African Americans also report higher levels of condom use and higher levels of HIV testing. Now, the end stage condition of HIV disease is AIDS. And thinking about AIDS is really useful because it usually signals, especially now that we have medications, poor access to care, poor access to services, people slipping through the safety net. This slide presents trends from 1985, just 4 years after the first diagnosis of what would become HIV/AIDS. So from 1985 to 2008. And what we see here is that while AIDS diagnosis, that's the orange line, and AIDS deaths, that's the blue line, have decreased over time since the highly active antiretroviral therapies have become available, HIV prevalence has increased, and that's a natural function of the fact that people are living longer with their medications. This chart shows the proportion of diagnosed AIDS cases by race and ethnicity from 1985 to 2009. And the first thing we see here, if you look at the maroon line representing African Americans, is that the proportion of AIDS diagnoses among African Americans has increased fairly steadily over time since essentially the beginning of the epidemic. And around 1994, it actually surpassed the proportion among whites. So we see that there are disparities over time among African Americans. But if we just look at this cross-sectional period for 1985, African Americans represented 12% of the population at that point in time, and the HIV epidemic at that point in time was characterized as a gay white male disease. And yet, African Americans represented more than twice their share of the US population in terms of their share of AIDS diagnoses. So disparities from the beginning of the epidemic. And this slide shows rates of diagnoses of HIV infection per 100,000 population by race and ethnicity. And really the one thing I want to highlight here is just that the burden of HIV/AIDS in the African American community is many times greater still, up until 2011, than it is for other groups. So one way to look at all of these disparate outcomes and to look at the persistence of a Black disparity really in comparison to other groups is to think there must be something about Black people that's causing all of these different disparities. But there's another way to think about it. We can reframe those questions to take the emphasis away from thinking about Black people and what are Black people doing wrong, to thinking about what is it about the racialized social experience that Black people have in this country, or people who are racialized as Black. And a lot of research has been done. You heard Dr. Williams speaking yesterday and others talking about racism relative to a number of outcomes. Not as much has been done in the area of HIV/AIDS prevention, but focusing on social determinants within the context of HIV/AIDS is really potentially powerful because the HIV epidemic is, in many ways, an ideal outcome or an ideal condition to study because it reflects and reinforces the inequalities that exist in societies. So just to take a simple example, in societies where women have very little power over their own bodies or their sexuality, we may often find that they experience a disproportionate burden of HIV-related outcomes. So what we know from the other areas in which racism is studied as a social determinant of health is that Racism's contributions are complex and multifaceted. They reflect the ways racism's relationship to specific outcomes is tied to the ways that racism works in society more broadly, that it operates across all socioecologic levels. So we often focus on interpersonal discrimination, but racism could include internalized racism, John Henryism, the ways that our bodies respond and embody the stress of our social environments. It includes the things that happen in our organizations, communities, and even nationally in our policies and even internationally. There are direct and indirect pathways, and that when we think about racism, it's important to consider historical ways that racism had an impact, ways that those historical impacts might affect the present, and then also ways to think about the contemporary ways that racism might be at work. So these are two definitions. I mean, many of us have published definitions of racism, but I just want to highlight two, and really I'm going to draw your attention to the second one by Gilmore. I find these two helpful in thinking about racism within the context of social justice and public health. And Ruthie Gilmore writes in her book, Golden Gulag, that racism is the state-sanctioned and or extra-legal production and exploitation of group-differentiated vulnerability to premature death. So if the goals of public health is, as the World Health Organization asserts, quote, to attain optimal health for all, and if racism is, following Gilmore here, the production of systematic differences in a racial group's ability to attain optimal health for all, then we have to think of racism as systematically undermining the goals of our field, health for all. And addressing racism, therefore, must be part and parcel of doing good public health work. So where are we in terms of understanding how racism influenced HIV/AIDS disparities? So to understand that question, I enlisted the help of several of my students and undertook a systematic review of the empirical literature to try to assess this. We looked at articles that were published or indexed in the Medline or CINAHL Cumulative Index on Nursing and Allied Health Listings databases. The Boolean search strategy involved 3 sets of terms. Set A dealt with HIV-related key terms. Set B dealt with racism in general, or also in ways that it's tied to, that people often tie it to HIV/AIDS. And set C dealing with Blacks or African Americans as a population of interest. Inclusion criteria articles had to be published between 1994 and 2010. The studies had to be about Blacks in the United States, report empirical findings, and it had to be focused on racism of some sort, and we'll talk about that in a moment, just a little bit. We retrieved 393 candidate articles. 51 of these we retained for the purposes of our study because they met all of these criteria. So we categorize the empirical studies as primary, secondary, or tertiary. Primary studies, 27.5% of all of the studies, explicitly named the exposure or risk factor that they were talking about as a racism mechanism. For example, someone's self-reported experiences with racism, and then measured that exposure relative to some HIV/AIDS related outcome. The secondary group did not explicitly hypothesize a racism mechanism, but they reported racism when they talked about the findings. So often these were focus groups, for instance, where people were asking about barriers to services, and participants would report racism even though it wasn't explicitly asked in the introduction. But the majority, 58.8% of studies, did not explicitly name racism anywhere in the study, but we could tell that it was about racism from the nature of the research questions, the nature of the sample, and other study features. So many of these studies dealt with things like HIV conspiracy beliefs. And by HIV conspiracy beliefs, I mean literally asking participants whether or not they believe that the HIV epidemic represents a genocidal conspiracy by the government or by pharmaceutical companies to get rid of all Black people and other undesirable groups. So most studies were exploratory in that they generated theory. So they helped us to think about what are some different ways that we can frame our questions to get at exactly how African Americans experience race and the relevance for HIV/AIDS prevention. But most studies also focused on interpersonal discrimination. And if you study racism, you know that the interpersonal level is really the least influential of all the levels. If we think about structural mechanisms, even thinking outside of racism, those structural mechanisms really exert much more force on the outcomes than do the interpersonal ones. So more work is needed on macro level factors and on the intersecting relationships. So thinking about what does it mean to experience racism, not just because I'm a Black person, but because I'm a Black man, or I'm not meeting the definitions of what an African-American woman is supposed to function like. Other selected findings: perceived everyday racism was prevalent. Interestingly, higher levels of perceiving everyday forms of racism appeared to be associated with higher odds of preventive behaviors like HIV testing. So it's logical, and we've talked with community members about some of these findings in some of my own work, that in terms of everyday kinds of racism, African Americans have found ways to survive in the face of, being followed while you're shopping, for instance, because of racism. So we're looking more now to see, are there ways that resilience counters in, so that we remember that people who are victims of racism or of oppression also have agency and resilience. HIV conspiracy beliefs. An estimated 20 to 27% of African Americans believe that HIV/AIDS is a genocidal conspiracy. Another 23% believe that it could be a conspiracy. And this is true regardless of educational attainment or income. And in fact, in some cases, it's actually higher among the quote unquote higher SES groups. Racism-based distrust is also prevalent, and it's often tied to egregious medical racism, especially in the past, in terms of thinking about the Public Health Services study of untreated syphilis in African American men in Tuskegee, Alabama. Now, among HIV positive people, depending on the study, between 14 and 63% reported that they actually experienced racism from their HIV care provider. And 20 to 71% held HIV conspiracy beliefs. So these points, these data indicate that racism is salient in the lives of people who are disproportionately burdened by the HIV epidemic. And this type of empirical research is very important. And this touches on with what Dr. Fullilove was talking about. Can we do more than just document the findings? As academics, as researchers, as practitioners, can we actually form a movement around addressing it? Now, critical race theory is a movement that originated in the field of law among scholars and students in primarily prestigious US law schools, scholars and students of color. And the whole entire purpose of the movement is to explain and undo racism using the tools of our disciplines, as well as our experiences from being sort of in the margins of society, in the margins versus in the mainstream, so that we can radically change, and eliminate these racial hierarchies. Critical race theory contains within it the concept of private primacy. Primacy has two meanings. First, it means that racism remains a dominant ordering structure within our society. A second meaning of primacy is that for critical race theorists, we recognize that there are many things that influence outcomes, right? But that we are particularly interested in understanding what is that racial piece and how can we explain that. Positionality is central to critical race theory, and it says that basically where I stand in life, my social position, informs the perspective that I have. So if I stand in the center of the mainstream, there are many experiences about disparities, inequalities, the margins that simply I remain unaware of. Simply by my, let me get my pointer right, simply by my social location. Okay. Centering in the margins means that I choose, as a critical race theorist, to ground my work in a framework that is based on the experiences, critical analysis of the experiences born of being within the social margins of society. And so we can think of this as occurring in society at large. So we know that there are groups who are in the margins of our society, but we can also think about the ways that this happens within our disciplines and within academia, right? And so within academia, critical race theorists see themselves as scholars, researchers, and activists, grounding their work in the margins, remaining committed to giving voice to the experience of the margins and privileging that perspective in discussions about inequalities. So critical race theory can be a little bit unwieldy and large. It's from a different discipline. So noted health educator Collins Iriambu and I developed the public health critical race praxis to try to help people within the field of public health draw on critical race theory in ways that are useful for our field. So for us, our public health critical race praxis provides a process for integrating a race-conscious social justice orientation into the ways that we conduct empirical research, and also provides concepts relevant, developing a lexicon for talking about racism in more sophisticated and nuanced ways. So although critical race theory is called critical race theory, you should think of it more as a set of tools, methodologies, approaches, and even a movement. It is a race-conscious orientation, as I'll show you in a moment. Race consciousness is really particularly important at this point in time in our country's history because there's such an emphasis on color blindness, right? So if we are unable to talk about the ways that racism is functioned by naming it racism, then that really stifles our ability to touch the real core of the problem. So the key questions for public health critical race praxis are, how is racialization relevant? And I'm using the terms racialization, racial stratification, and racism interchangeably here. How is it relevant to this problem, to the particular study that I'm taking up right now? And then how is it relevant to the production of knowledge about this problem? And by the production of knowledge, I'm talking about what happens when we do research. Because when we produce research, we're creating truths. The public health critical race praxis has three main components: a race-conscious lens, which frames the entire research process; 4 focuses, which are essentially the 4 stages of the research process; and 10 principles, which are the basic tools of the public health critical race praxis. This is the schematic for the public health critical race praxis, and you should think of this as essentially a roadmap that researcher can use literally as you're carrying out your research project. So the first phase is, the first portion is just really race consciousness, sort of sitting down and establishing a personally race-conscious orientation to a proposed endeavor, clarifying how racialization is relevant to the issue, and undertaking a self-assessment to see, what are the biases that I bring to this work in terms of my own thinking about race and racism, am I imposing this on the community, et cetera. And it's important to note that this is an assessment that even if I identify as African American, I need to do in relationship to the work I'm doing with an African American community. In Focus 1, we focus on contemporary racial relations to try to understand the ways that racism, to make sure that the ways that we study racism reflect the ways that racism is operating today. Right, so you all may have seen studies in which people measure racism, but the measures reflect outdated ways that racism operates. And so those estimates are not going to be accurate. How can we develop accurate, more relevant and timely measures of racism? In Focus 2, knowledge production, the primary goal is to think about the implications of this work in a race-conscious way relative to the existing literature. For instance, does the prior literature on a topic, explicitly or implicitly, reflect assumptions that your proposed research fundamentally contests, right? And if so, then you need to sort of write out exactly how and why that is. One example might be that there are a lot of assumptions about Black sexuality that actually does inform sections of work on HIV prevention. So why might you contest that as a starting point for the project that you're beginning? From focus 2, we move to focus 3, conceptualization and measurement. And here we essentially operationalize the variables using a race-conscious frame. This is an iterative process, obviously linking to the existing knowledge. And one way to approach this is to compare conventional operationalizations, conventional measures to novel ones and try to refine the ways that we think about racialized measures in public health research. So the public health critical race empirical process comes full circle with action. And here we use the knowledge gained from our study to try to disrupt or otherwise respond to one or more causes of the inequities. And these kinds of action steps might be like trying to make an intervention in the literature, expand the vocabulary, use counter storytelling that's grounded in the margins to explain or clarify problems from the perspective of community members, or even directly challenging identified disparities. And this, of course, can also inform knowledge production and measurement. So there are 10 principles. In the interest of time, I'm not going to linger on the 10 principles here, but these are the principles on which a researcher leans as they're working in each of the focuses. There are different principles assigned to different focuses, but let me just draw your attention to several. Race as social construct, social construction of knowledge, intersectionality, and taking action. And each of these, I think, is really useful for HIV/AIDS prevention research. So race as social construct has two connotations. We often in public health talk about race not being biology, right? But it also has a connotation which is about what race is, not just what it isn't. And as Heyman and Levitt put it, quote, "The ways in which race orders and constrains us have reconstitutive effects and ensure that race becomes in social fact what it is supposed to be in naturalist theory, a differentiating trait that orders us in hierarchical terms as members of inferior or superior races." And based on this construct, several of my studies have tried to reconceptualize what race means in a study so that we're looking less at person characteristics and more at the experience that one has in society as a result of those person characteristics in a racialized society. Social construction of knowledge. Knowledge production endeavors are shaped by and thus reflect historical, sociopolitical, ideological, and other factors, and this is particularly important to remember in the sciences where there's such an ingrained notion that our work is objective and therefore not likely to include any kinds of biases. But, as Larry Bobo makes clear, data never speak for themselves. It's the questions we pose and those we fail to ask, as well as our theories, concepts, and ideas that bring a narrative and meaning to marginal distributions, correlations, regression coefficients, and statistics of all kinds. In terms of what we are likely to learn from a study, if we think about the social construction of knowledge, I think a paper titled by Steve Wing really says it all. Whose epidemiology? Whose health? So part of the realization that we as researchers are involved in a social construction of knowledge, realizing that means that we have to also engage in critical self-reflection in the work that we do. Critical self-awareness, especially regarding personal privilege and racial relations, can inform a research team's interactions with community members and with study participants. It can inform the ways that we relate to the people on our project teams. And it can also inform how we interpret our study findings and the privilege with which we discuss the findings from our research. Now, in the context of HIV, the notion of intersectionality is very important. And it says that the systems that create different social strata intersect, right? So sexism and racism intersect. And therefore, those categories also intersect. And one cannot simply separate their blackness from their genderness, right? So complex interrelations exist between social identities. And this was really a crucial point for a paper that several colleagues and I wrote, really challenging the field in terms of how we think about Black bodies in the context of the down low. And you've all heard of the down low. Okay, so we offered 3 critiques. One was that scientific research is this type of scientific research is inherently tied to the social context, right? So understandings about Black bodies and Black sexuality in the context of science is not disconnected from understandings about Black bodies and Black sexualities that exist in society more broadly. So any study that attempts to examine, social determinants tied to Black sexuality necessarily has to deal with issues of racism, because in this country, racism has always been linked to the sexualization of Black bodies. And so not doing this has implications for scientific rigor. It has implications for the ways that we relate to the communities that we're working with. I've listed some of them here, but in the interest of time, I'm going to move along. Okay. Finally, what actions can a researcher take to move beyond merely documenting study findings? And in one study that my colleagues and I undertook that dealt with perceived everyday racism in HIV testing, we took several what might seem like small steps, but they are really part of our effort to be responsible from a public health critical race perspective. And the first is, obviously, we reported the findings in the scientific literature. We also disseminated the findings through presentations and shorter write-ups to community members, study participants, frontline public health workers like health educators, and to clinic staff. Now, importantly, many of the frontline public health workers, the outreach workers, wanted us to sort of speak on their behalf to clinic staff because they shared much of the knowledge that our study just validated, but they did not feel comfortable sharing this with the clinic staff, and they felt like they would not be well received. And so that was a task that we did. We're working on revising how we can think about racism-related concepts, right? So is it the same to talk about perceiving everyday racism outside of a clinical setting versus talking and thinking about the ways that racism might occur within a clinical setting? Are there different connotations? Do they hold different relevances for people? And are there implications for HIV/AIDS disparities? And then, and our findings allowed us to do this fairly easily, but to try to be open to alternative interpretations of minority behavior, especially promoting possibilities that don't simply reinforce negative stereotypes of minority communities. Thank you. Okay. So in conclusion, racial ethnic disparities in HIV/AIDS persist, but racism's contributions to these disparities are not well understood yet. Racism's contribution is not well understood yet. And we believe that advancing a public health critical race praxis movement within the field of public health could be a very powerful way to begin to address this. One thing I do want to add is that in order for this to be successful, we think that the African American community and allies must see the kinds of disparities that we see as a gross injustice, right? And this cannot be normalized. And health crits, critical race theorists within public health and others, must go beyond merely documenting these disparities and use our voice to contextualize the role of racism and to take actions based on a social justice, racial equity commitment. So there's some information if you're interested in learning more about public health critical race praxis. I'd like to make the following acknowledgments. And thank you. I have time for some questions. And I know that there's a lot of density in some of the discussion about racism. So for that, there's not really time to get into it in a talk, but there are several papers there's a couple of papers in the American Journal of Public Health, and also in the journal Social Science and Medicine from 2010, that kind of walk through these very, kind of in a straightforward way. There's also another paper in the Annual Review of Public Health from 2011, I believe, by Stephen Thomas and Sandra Quinn, that walk through public health critical race praxis. Okay.
Thank you very much for your talk. I was wondering if you could elaborate. You mentioned the community health workers finding that your research findings validated their experience and asked you to communicate it to the clinic staff. So I wonder, in particular, what did they find to be validating, and how did you go about communicating with the clinic staff? Okay,
so the main finding was that many participants in the study believe that racism was very pervasive. And even though in that particular paper we don't detail their experiences with providers in that particular setting, that was something that came out in the course of the research, just through data collection, people shared with us. But that was also something that many of the frontline outreach workers already knew, because for one thing, many of them have been through some of the same experiences, and they worked with people. They worked with people in the community day in and day out, and they understood and they heard these same kinds of complaints from community members. So what we did, and actually several of the lead outreach workers for the area came and attended a discussion forum that was geared towards the public health clinic staff and the affiliated staff for that clinic. And I presented the findings from the study, and I gave them supporting documents about the research and copies of the paper and so forth. And there was a very mixed response. In general, I think from the top down, it was somewhat there was a strong sense of resistance, because I think that many felt like, well, I'm not a racist, right? But the purpose of the research was not to prove that any particular entity is a racist. If our communities experience racism in the context of getting health care, then it can happen anywhere. And our goal is to try to understand, well, what are the implications for early diagnosis of HIV infection and for getting people into the care that they need. So there were several African American staff people who really wanted to pull me aside and have this quiet, secret conversation that I agree with you, and this is really important, and it's an issue in our clinic. But there was also a tremendous amount of resistance and pushback, even weeks later from the clinic, that was essentially trying to challenge the study findings.
So, one of the things that I attempt to impress upon my students is the importance of knowledge translation, knowledge transfer, taking evidence and making sure that it gets into the hands of those who ideally are interested in doing something with the findings. And so I just want to underscore and congratulate you and Dr. Erhayambua for ensuring that there are action steps that follow. It's a lot easier to remember than knowledge transfer or knowledge translation, the idea that you actually take action steps. But your response to my first question raises yet another, which is, how do those of us who are in public health or community health actually engage in social action for social justice on the part of the community when there is this kind of resistance, and there could even be pushback. And so the one thing that I want everyone to hear is that if you are in a clinic and you still want to get your paycheck, You want to use someone like a Dr. Ford who just happens to come in for a grand rounds. You want to, in private, go up to them and say, this is happening here. Because the reality is that there can be both resistance and pushback. But then, for those of us who embrace this kind of paradigm, it's really about mandatory cultural competence training that we also then need to go to the administration of these organizations, that we have to do a kind of advocacy, that the minority workers or those who are observing what's going on the front line because they want to keep getting their paychecks, they may not be able to say, I'm observing and indeed understand why AIDS patients or HIV positive patients are reporting racism in their care. And so again, we have to really think about what does that look like? What are the mechanisms that we create other than a publication where we actually put upon the public health services the onus that you have to do something, that there is a need for this kind of mandatory cultural competence training.
I think that's important. I think that process is also important. So regardless of the outcome, just talking with community members and folks at the outreach workers and so forth, for them, they expressed that there was such a sense of validation that I am hearing what I'm hearing, that I'm doing the right thing, and that was really important to them. So I, for one, will sign up to go and do the work of talking to the clinic staff or to others as needed. But what I'm calling for, what we're calling for, and I heard Dr. Fullilove saying this too, is we need a movement within academia too, right? So we need people who are willing to say, okay, sign me up and I'm willing to work, that I'm not just talking about, what my empirical studies say, but what can I bring as a human being, connecting to other human beings in academia and to other human beings outside of academia, and as a way of addressing these health disparities. Yes. Hi.
Could you talk a little bit about the critical race practice institutes that exist, and would you mind putting the resource slide back up?
Okay, sure.
Thank you.
Okay, so last month, February, the University of Maryland hosted probably the first national public health critical race praxis institute, the University of Maryland Center for Health Equity. I would Google that because I think they have a lot of their resources still available. And the purpose of it is actually to build a network of scholar activists, researcher activists within the field of public health. And so there is a lot of jargon, there is a lot of, just finding the language. But Kamara Jones said a while ago, actually in 2009, we had a think tank at UCLA, and she used a term which I think is very appropriate, and that is organic critical race theory within public health. So yes, the formal critical race theory was originated in the field of law. But there are people who are doing the kinds of things that we're asking for and who have been doing this for generations, right? And don't realize that we're all talking the same talk. So part of what we're trying to do is say, let's come up with a common language. Let's come up with a way of standardizing what we're doing so that when I'm arguing with my, a colleague who doesn't agree or who doesn't get it, that I can point to your work and you can point to my work and they can say, oh yeah, you're not just making this up. This is tied to a system, a way of thinking. So that's what we're really trying to do. We're really trying to build a movement that's a race-conscious, social justice movement within public health research. Not everyone's not focused on HIV/AIDS. That's just my area. And so if you go to the Public Health Critical Race Praxis website, the top one, you'll find a number of articles that provide a really good sort of list of resources and background. UCLA, I believe, is the only school still that has a formal critical race studies program in their law school. So crsonline.law.ucla.edu, you can find a lot about critical race theory there. And also there are some upcoming conferences on critical race theory at UCLA later, I believe in October. And then if you go to CRT-health at Yahoo Groups, there is a listserv that doesn't get a whole lot of traffic, but maybe now it will. But resources and conferences and upcoming events are usually listed there. Thank you. My pleasure. Okay, any other questions? Well, thank you.
Oh, we have 3 minutes. I'm sure Shamika can come up with a question. Come on. Okay, go ahead. Okay, just repeat the question.
So the question was, how is public health critical race praxis being used beyond HIV/AIDS? You're really stretching my mind there because I'm so focused on HIV/AIDS. But there are several, actually there's an example in terms of mental health, thinking about mental health outcomes and complicating them, because we know, for instance, that African Americans might be more likely to be misdiagnosed or overdiagnosed for some things, perhaps underdiagnosed for other things, and then perhaps not get diagnosed. So I think there are some complicated racial dynamics to that as well. So there's a paper by Tony Brown that's it's at least 10 years old, but it looks at that. Mental health is one. And then also I would check the Public Health Critical Race Praxis Institute at the University of Maryland, because they have scholars who are doing it. But part of the reason why I cannot offer you more details is because this really is an emerging thing, and our most recent papers, our oldest papers are really only from 2010, so this is really sort of on the ground floor. But whatever you're doing, that might count. We might have to get you in. Uh-huh.
Hi, thank you for the compelling talk. So you talk about how racism is a social construct, and so I wanted to know, if it is a social construct, why do we continue to use it to classify and label people of color?
Mm-hmm. So that is a huge issue that's the focus of some ongoing work of mine. Part of it is that we lack the vocabulary to be able to talk in more complicated ways, right? We don't. What term would we use, right? So part of what this project is about is developing literally new words, right? Creating new terms so that we can do that. But the other part of the question is tied to what I meant when I said race is real in a social context, right? So the fact that I have a certain physical appearance means something when I go out on the street in terms of how I'm treated. And capturing that physical appearance, even if I have to use the word race to do it, helps me to measure what it means to walk around in the street with this physical appearance. Okay? Okay. All right, thank you all.